So, again, if someone says to you medical care is a right, they are creating an obligation. That created right is the taking of property from one person by force for the benefit of another. A person who is forced to work for the benefit of another is called a slave. Life's necessities, including medical care, must be available and affordable through free market devices, which always seem to work really well when the government stays out of it. So let's talk about three aspects specifically of Obamacare that will destroy the quality and availability of medical care for all of us. The first thing is the Independent Payment Advisory Board, the IPAB. Now, the IPAB is not what was created initially in this effort. The initial board was called, and I always have to look at this because it's long, the Federal Commission for Comparative Effectiveness Research. Now that sounds really good. Who would not like to have some comparative effectiveness and study about it a lot? That's what the research part of it is. And a commission means that you got a lot of people with lots of brains sitting around a table trying to figure all this comparative effectiveness out. That, believe it or not, was part of the original stimulus bill. It's already there. They're already trying to figure out comparative effectiveness for all of us. This was distilled down to be called the Independent Payment Advisory Board in the Obamacare bill. It's shorter, and a lot of people were kind of catching on to the other thing, what it was really meaning, so they wanted to change that. Now, you know that if you read all 2,700 pages of that bill, there is no section in there that says death penalty. You won't find that. It's not section 35B, stroke 1, paragraph 2. This is the death penalty. No, you won't find that in those 2,700 pages. But that's what the IPAB is. The IPAB is tasked with the necessity of determining the cost effectiveness of medical care. What is cost effectiveness? Well, cost effectiveness, very simply, is this. How much does this procedure cost divided by the life expectancy of the recipient? If there's anyone here who, well, I don't know, if people went to government schools, they may not be able to do that math, but if you have had any kind of reasonable math training, you probably understand that the bigger the bottom number is, the lower the cost effectiveness is going to be. So who does that hurt? Well, the older you are, the more it hurts you. And the older you are, the more likely you are to need some kind of medical care. Sometimes a costly medical service, like maybe coronary artery bypass, or stents, or kidney problems, or diabetes, or whatever. These are expensive. And if you have a life expectancy of 5 years, as opposed to someone with a life expectancy of 40 years, who's going to get the care? And so that's why the IPAB is a death penalty, without the name, without the title. Let's talk about another aspect, and that is medical records and approved practice patterns. This is a very diabolical section of Obamacare. First of all, you all know that we are now being forced to go to electronic medical records. I have transferred my practice 3 years ago. I'm completely electronic. All of my data from all of my patients is on a computer, a server system in my office. Under Obamacare, the federal government and Medicare, whoever services Medicare, has the right to come into my computer and get the information that they need. Well, I shouldn't say that. To get a little bit more information than they truly need. because they can get a lot of information from my medical records. They can get your birth dates, whether you're married or what your marital status is. They can get a lot of information that has no relationship. As you know, I'm an ophthalmologist. They can get a lot of information that has absolutely nothing to do with their eyes. All that information is there, as well as a lot of personal data. All of that, every single last drop of that, everything, every single 0 and 1 in my medical record is available to the federal government. So they'll know an awful lot about you that you probably would not want them to know. We used to ask it, or we do ask it, for our completeness. We don't even need all of it, but it's there. And the government now has complete access to it. So what are they going to do with that information? They have, let's see, the cost effectiveness of every procedure for you. They have a whole bunch of private information about you. So what happens in real life when a couple years from now there will be real-time interaction between my medical records and someone related to the IPAB, or Independent Payment Advisory Board? What's going to happen? Well, I'm going to examine a patient, I'm going to reach a diagnosis, and I'm going to fill out the diagnosis screen. I'm then going to go to the treatment screen, and there'll be a list of options provided to me by the government. Some of them will be grayed out, and I will not be able to click on them, because the government is going to be telling me I can't provide this service to that patient because the government doesn't want you to have it because of your age, or maybe because who you voted for in the last election. They can use any criteria they want. The IPAB is not made up of doctors. Oh, there could be a couple on there, but less than half of those 15 people can be physicians. Their decisions cannot be overturned. They cannot be questioned, except by a supermajority of Congress. So, right now as it is, if the doctor says, I'd like to do this for you, and your insurance company says no, well, you can go and complain to your insurance company, and you might be able to get by, and they might change their mind. But if 15 people in Washington, D.C., who you did not vote for, you have no call over, you do not do anything with them if they're the ones who are making decisions, and they don't have to even listen to you, why would that decision be changed? The basis here is that medicine is both an art and a science. That's critical to understand. When I treat patients, and I've been a practicing physician for 36 years, 36 years of experience I have in treating people. I know what works. When patients come into my office with a problem, I look at them, I say, here's your problem, here's what's going to fix you up. I didn't learn that in a book. I learned that because for 36 years, I've been treating people with that condition, and I know what works. What the federal government is going to say, okay, if you have this diagnosis, the first thing you got to do is this. If that doesn't work, you can do this. If that doesn't work, you can do this. If that doesn't work, you can do this. Well, what if I already know that 1, 2, and 3 don't work? I want to go right to number 4. Unfortunately, I can be fined severely and thrown in jail for doing that. What does that mean? That means that physicians are no longer free to treat you the way they know will be a successful treatment and cure you of your problems. We already, and this program has not been implemented all the way yet, probably another 2 years or 3 before it actually has to be done. Right now, for chronic disease like this, I have to put in 2 codes. The first code is whether you are a diabetic or not, and whether you are controlled or uncontrolled diabetic. The second code is what's wrong with you. Do you understand what that says? The first thing they want to know is, are you being a good boy or not? Are you controlling your sugar or are you not controlling your sugar? Because what's the next step? You're not controlling your sugar, so you can't get the treatment. That's the next step. We're already having to do that. That is required right now.